shrinks. No matter which strength composite you are using, it won't stay. You agree with me? So how many failures did I cover till now? Discoloration, dislodgement, debonding, micro leakage, secondary caries, post-operative sensitivity. Because your bond did not see the dentinal tubules are left open, therefore they are getting post-operative sensitivity. Let's look at this surprising thing. Have I covered all the failures here? So now after out of etching, bonding and curing, which is the most important for you?
All three steps.
Come on.
All three steps.
And what do you do at the time of curing? The classic act at the time of curing is suction down the pakad. You're distracted at the time of curing, your hand is shaking, you're either looking for the next shade to pick up. You are protecting your eyes, therefore not looking at curing. So first thing, when you're doing curing, it has to be a complete focused action. You have to look at the light. Therefore, you have to buy your eye care. Okay? You have to give it to the patient also. While you're manipulating the composite, and the composite you feel that it is getting set while your chair light is on, use correctors. Because if it's a composite, it will set in your dental chair. Only if it's when it's a compound or a geomer, you get more extended working time. So the material is coming out from the same syringe, but we are not having this understanding. We get referred to a side where they are having more time of manipulating the composite. But that's not composite if it's not setting in your dental chair light. Am I clear? So buying a filter when you're manipulating the composite is also essential. Now where do you hold the curing light? Let me quote literature here. When a curing light travels a distance of 6 mm, it loses 50% of its power. What power is your curing light? Now that we come to know that curing is the most essential among the three parts in etching, bonding, and curing, I need to know more details about my curing. So, what power is your curing light? Come on, shoot some numbers. 440 nanometers. Anybody else?
410.
410 nanometers.
Yes.
Anything else? Unfortunately, this is the only number that we know. 470 nanometers, 440, 450. This is the wavelength of the light. It's not the power of the light. It's the color of your light. That has to be blue. So you take your light, my light, anybody's light. It has to be within that spectrum. It has to give you a blue light. That's not the power. So if I classify the power of a curing light, now why do I need to know this? Because you came to know that curing is the bullseye for all my composite restorations. So I need to purchase a curing light accordingly. How do we go and purchase a curing light? Do any one of you know the cost of a curing light? चलो guess कर लो. How much? 40,000. 40,000. Anybody else?
3,000 to 15,000.
Sorry?
3,000 to 15,000.
3,000 to 15,000. 1,05,000. Can you see the meaning? I can give you a curing light in 600 rupees. You want that? 1,800. I can give you a disco curing light also. We have nil knowledge about the most important instrument in our practice. 85% of clinic revenue is dependent on a curing light. Can you imagine? Irrespective of your fraternity, even if you are a periodontist, 85% is affected by it. Any dental procedure you do is 50% dependent on dental curing light. And the only number that we know is 440. So any manufacturer is going to give you 440. Today, I want you to understand how to purchase a thing so that you get a complete best clinical outcome out of it. We are only bogged down by higher numbers and looking for इसमें high strength है क्या? इसमें ये है क्या? And the person comes back and tells us ये 10 generation bond, ये 9 generation bond. We are totally nil about it. Once you step out of the college, are you going to go back and read your textbooks for this purchase? What are you going to read? कितना ml है, कितना ग्राम है, कितने यूनिट्स है, and then you divide that cost into per unit and get satisfied in an exponent by filling up your bag for the whole year of your practice. We are not taking informed decision in purchasing our material. And do you feel that material plays a role in your dental practice? How much percentage would you like to give that? If material was to play a role in your dental practice, how much do you think your skill and how much percentage is the material skill? How much would you like to give? 60-40? Anybody else? Even if you give 1% to the material science and you feel that you are 99% excellent, that 1% is still dependent on your success rate. I am a good chef. I know how to cut fine, thin slices of onion. But if my knife is not sharp, can I do anything? It is as simple as that. And I don't know how to purchase a knife. That is the biggest loophole in our practices today. And the second loophole is not having a follow-up of your cases. Because once the patient came 2 years back to you, your cases still. How do you say it's successful? ऐसे तो कितनी सारी स्टडीज हम पब्लिश कर देते हैं, इतने सारे केस रिपोर्ट्स हम पब्लिश कर देते हैं. Follow up is hollowing your practice. If you are not having a follow up, you are not having a healthy practice. You are having a hollowing practice. You are only pulling new patients and there's a hole down in your practice. Two learning things. Third thing is to obviously go for the oil-free compressor. So those people who imagine their clinics, can you imagine all of this in your clinic? Yes? Amongst your dental materials, your first master is a curing line. To purchase a curing line, what are your criteria? Can you think of any? Here, I give you from 600 to 1.5 lakhs. 2.5 lakhs is also there, sir, if you want to purchase. So I'll be sharing my homework with all of you. Since I don't have time over here, I'm going to cut short this by telling you that you need to be specific in your needs for purchasing a curing line. I would like to go, those who want to note down can note down, a monowave, narrow spectrum, a medium intensity light, not high, not low, medium specifically. So when I say medium, it should be between 1000 to 1500. Then I will ask your manufacturer, iska variance kitna hai. That means, as I said, a powerful light at 0 mm is giving me 1000. But when it goes to 6 mm, it becomes 50%. अब मेरी इंटेंसिटी उतनी रही नहीं. Yes or no? है ना सही खड्डा. बट सारे फेलियर्स यहाँ पर आ रहे हैं. So I want a variance which is between 10 to 20%. I cannot afford anything more than that. And then I'm going to do one thing very specific in my clinic. Every new purchase that I make, okay, I'm skipping all of this. I need to read this. Since you were not reading the black and white paper in 26 languages, we gave you colored paper. And what did you do of that? You made it a nice mixing pad of it. Yes or no? You agree? Every company will tell you how much cooking is required for their resin. Okay, it's not instant noodles. So if I am taking 4 mm of this bulk film material, I need to cure it for 20 seconds. And can you imagine 5 mm material to be cured in 30 seconds? If I'm doing a deep class 2, I can finish my curing within 30 seconds. Application will take if I'm using a computer, it will hardly take 10 seconds. If I were to do it in a conventional composite, I would be taking 3 increments, each increment 20 seconds. And imagine the last increment, which is at your 6 mm, is it getting a full intensity? No. That is the first one which is handled by shrinkage. That is why all our classes are becoming RCs. And of lately we got bored of that also. तो patient आते हैं हम क्या बोलते हैं RC. We don't give it a chance. Okay? Reading this, now this is another confusion where ये तो मैंने पढ़ लिया. Okay, this is one company's instruction. And if I go to Ivoclar, I have another instruction. If I go to another company, another instruction. How do I uniform this? Do I keep buying new lights for each composite? Or do I restrict myself to one set of manufacturing? No. After doing a lot of research, you can note down this number that at least you need 850 milliwatt per centimeter square as your intensity at the sixth level. For that, my light has to give me at least double the power on 0 element. That is why my light has to be between medium intensity. It cannot be low because it will not cure. If it will be too high, what is wrong? If I'm using intensity which is 2000, 3000, what is wrong? Hello? It will be better, right? All these lights with high intensity will default not go beyond 3 to 5 seconds. So you have 1 second cure. The manufacturer knows that if I give such a high power of intensity, the bulb is going to deep fry. By default, all these lights will switch off after the third second. And what is the output energy? Can you see over there? Can you read how much is it? And the same thing on the standard light, how much is it?
14.
Are you looking for intensity or are you looking for energy? If you're looking for energy, you need to give that energy to each monomer so that it becomes one polymer. Are you getting it? People get what do you say गुम हो जाते हैं high intensity बोलकर. आपको उसमें नहीं होना. Got it? Now what are the clinical tips for curing light? Let me skip this. I will never buy a light which is having two bulbs. That is why I said mono wave. Because एक बल्ब खराब हो गया तो मैं चेंज नहीं कर सकती. और मैं बल्ब में can you make out? This one is having a little lesser intensity than this one. हमारी तोड़न में पता चल जाता है ना this one is not flickering. Can you do that in your curing light? And how many times, question to all the practitioners, how many times have you purchased a curing light in your life? एक जो चेयर के साथ आती है वही चलती रहती है. When you characteristically see your restorations becoming yellow and your bonding agent becoming yellow on the second or the third day itself, your light was so weak that it could not hit the photoinitiator of the composite. Camphoroquinone is haldi in color. In this case in Naya Dental College, where we gave them a whole good kit of composites, they were doing occlusion stamp technique. 10 days का follow up के बाद I got a call from Dr. Kakde, HOD of PDO. क्या composite दिए? सब पीला हो गया. We went and we checked their intensity on a spectrometer. You get this spectrometer, this thing that you see earlier. You get this spectrometer from Blue Light Analytics. Not easy to purchase. I was fortunate enough to be attached with 3M. And we found their intensities to be 115, 150, but they're all turning blue. So can you say their light was bad? What is the magic number that you need to look for? What is the magic number? Come on. 850, where? At the base, at the 6th mm. If you get impressed with 850 at 0 mm, you are in low intensity category. Okay? Can you see the difference? Both are blue. So my first informed decision in aesthetic dentistry is to buy a good curing light. To understand how much my company or my composite is asking me to cure for. If you go to an A3 shade which is 2 mm, do you think you can cure it for 20 seconds? You need to read. If you are using a dentine shade or an opaque shade which is A1, do you think you can cure it for 20 seconds? We are not aware of it. We just arbitrarily keep thinking 20 seconds, 20 seconds. मन किया तो एक और साइकिल दे दी. आइसोलेशन नहीं था इसलिए एक और साइकिल दे दी. Is that going to work? Okay? You should always go for at least 10 mm. Can you see the reason? Yes or no? So nobody cures their bonding agent step in a classroom 2 times. They only cure it for one time. 10 seconds. So you know where your failure is coming, why your proximal boxes are falling off. Can you see this? Now if I keep my light away from the tube, I'm going to give every millimeter is going to reduce the power. So I need to keep it close as possible to the tube. When I did that, I started getting this on my curing light. That means the resin is touching. There are scratches. This will reduce your intensity. If you're using RPG sleeves or thicker plastics, it will reduce your intensity. So clinical tip, 1 or 2 seconds away from the tooth, then touch the tooth. When you use a medium intensity light, the patient is going to feel the heat of the light. You need to train the patient or inform the patient prior, especially when you're doing deep class 2s or a class 5. Okay? But what happens when in the first 5 seconds your patient is, so you go for a lower mode of light, yes or no? No. If you go for a lower mode, how will your bonding agent cure? That's the standard intensity you need.
Hello?
You are now trying to treat an active pulpitis case into a filling. Because as you go deeper, what happens to the dentical tubules? They get wider. Radiographically, you're seeing dentine, but histologically, it is pulpitis. So I applied bonding agent, and first 5 seconds, my patient is having unbearable sensitivity. It's a case of RC. Okay? What kind of angulation do you need? So this angulation is specific because हम light ऐसे ऐसे किसी भी angle में रखते हैं. The direction should be perpendicular to your resin. Okay? These are a must. If you have detachable parts, please clean inside the dust. इसका मतलब ये नहीं कि उसको पूरा disassemble कर दो. ठीक है? And you should have detachable probes. Would you like transparent probe or black probe? Black. Okay? 10 mm guide. And it should be detachable. At least in a month or in a week, I should auto clean. So how do you sterilize your curing lights? सभी को नहीं है. Use a spirit or a surgical alcohol which is completely squeezed. And then you wipe it out. So my assistant takes it, she wants to be extra sure and she pulls the spirit on the curing light. It's an electronic equipment, खराब हो जाएगा. And I teach my assistant with the price. This is for 85,000. This is for 10 lakh rupee per liter. This is for 6 lakh rupee per kg. Please use it wisely. Okay. You have to have a radiometer in your clinic to check the intensity of your light at least a week. In a week. Why? It's an electronic equipment. Do है मतलब ये नहीं है कि उसकी intensity वही है जो आपने परचेज की थी 2 साल पहले. आपके फोन की बैटरी भी वो होती है ना. So you come to know I need to frequently charge it. And that's the very late stage in a curing life. Before that only you start getting failures. And off lately with all these failures, we started settling into a zone where if I ask you कि आपका composite कितने साल तक patient के मुंह में रहेगा, you will have an expectation of कितने साल हम patient को बोलते हैं. Patient को तो हम दूसरी बात बोलते हैं. आप अपने मन में क्या सोचते हो? 2 साल, 3 साल, anybody agreeing 5 years तक मेरा हर composite रहेगा? Do you think 5 years after her composite रहेगा? Every case that you do. You expect that. But does it stay? At the max 2.5, 3 years मिल गया तो you feel हाँ it's a successful case. A meta-analysis of anterior and posterior restorations was done. 3,000 restorations were evaluated. How many?
3,000.
3,000. Out of which 49% survival rate was 9 to 12 years. How much?
9 to 12 years.
And 15% was 12 to 15 years. So if you use the right material with the right science application, you are bound to get these results. Now you imagine the kind of composite charge restoration that you're taking from the patient, which is going to survive for the next 1 decade. Should you be charging so less? Because we are unaware of these results and we think that these are only going to be internationally available for us. It's not like that. It is not like that. Once you read and then purchase, and then with your understanding, when you imply it, you get much more confident and predictable. So I'm thankful to the team today for giving me this opportunity. I want you guys to open your mind before any purchase. How much do I need and what am I getting? Rather than ये क्या बेच रहा हूँ मैं इसको कैसे यूज करूँ? After that we are doing that, right? ये isolation में काम नहीं करेगा. You start maintaining isolation. आप मुझे ऐसी चीज जो isolation में काम करे. I'm a dentist. I work in sea. I work in water. How can you give me hydrophobic things? Am I making sense or is it too rebellious? So we are always adjusting. Okay, now this is in brief. What would be your start to end procedure for an aesthetic restoration? If you want, you can take a picture of it. And yes, at the first time when I did, it took me half day to imply to all of these steps. But when I did my first RCD also, it took me half day. Practice makes it easier and faster. So till what time should you practice? What is the quote that comes to your mind when I say practice? Practice makes a man perfect. Just sleep that quote. Practice until you cannot get it wrong. So all the endocrines, if I ask you to do a composite restoration, can you do anything wrong in it? No. You know how to do it, even in your sleep. So for anything when you formulate a standard guideline, now you have to explain the same standard guideline to your wingman. Who's your wingman? Your two assistants in that two-chair clinic. Once you train them, 80% of your workload is sorted. Okay? For any case, my highlighted option is not to look for indications. We got into a mindset of खड्डा दिखा भर दो, दर्द हुआ खोल दो. I mean खोल दो, not even खोल दो. Look for contraindications, and most of the time when you step out and you're into your private practice, you after completing your procedure, now you tell all the things to the patient. ये करोगे तो ऐसा हो जाएगा, कुछ कड़क खाओगे तो निकल जाएगा. Do you think that is the right way? Why will the patient trust you then? That is why he's got into a window shopping habit. I am a doctor who will ask my patient, okay, all the work I'm seeing in your child's mouth, I will fill it up. What are you going to do as a parent? We have gone into a cycle of committing, over guaranteeing our work prior so that we can retain the patient. No, it should be the vice versa. Take commitment from the patient. So when the patient is about to ask me, आपकी feeling कितने time तक रहेगी? I ask them, what is your age? 42, 24, 38. You had natural enamel, which is supposed to survive 100 years. In 24 years, what did you do? So am I making a Taj Mahal in your house, in your mouth? I have lost patience. I have got bad reviews. But the ones which I have retained, I have retained. So instead of we giving a commitment, take commitment from the patient. Are you going to give me follow-ups? Since you know that you've lost your natural enamel, are you going to give me follow-ups or not? Only if you give me follow-up, I can intervene. I can help you out. Are you going to maintain oral hygiene? Are you going to imply to my diet counseling? Again, for that, I should know what I should be telling my patient, which toothbrush to use, which toothpaste to use, how to use, when to use, what to eat, what not to eat. So do I do it on the day of my consultation or the day I completed my treatment? This is a paid session and my knowledge is valuable. I read through articles and then I come to a conclusion. I have told this to my other patients, and with their experience, I can tell you that this remineralizing toothpaste is a very essential part of your oral hygiene. These are never told on the day of consultations. These are never told on the day of treatment. These are told on the follow-ups. When you again show them that this anterior restoration which I did for you is having plaque. This is the reason why it will fail faster. Can you now buy an electric toothbrush?
Yes.
Can you now start brushing in the right direction? Are you guys with me?
Yes, ma'am.
Sleeping
No, ma'am.
or imagining?
Imagining.
Thank you. Okay? Now, one point here. Can you see case is to patient counseling? I never do patient conversion, patient convincing. It's education, it's counseling. So I display my failures prior to the treatment. ये कॉम्पोजिट है, कुछ सालों बाद ये श्रिंक होगा, ये कॉम्पोजिट है, कुछ सालों बाद इसमें डिस्कलरेशन आएगा. आपका दांत उतना मजबूत नहीं है कि I can go for a ceramic veneer. You need to explain that. No matter how many, so there are no options in the clinic. I have a metal crown, I have a clear crown. That's not there in my clinic. There are only two options. One restoration which I will do, which I'm sure of I'm going to do with composites. Another restoration which comes from the lab. I decide whether you should go for a metal cap or not. I decide whether you should go for a E-Max partial bonded restoration or not. Because at the time when anything happens, you're going to come and talk to me, right? I better tell you what to do. Please make a note of this. So for which all cases should you go for a mock-up? Quickly, I have 200 slides. So initially I had this mindset कि जब तक 16 years नहीं है mock-up में खर्चा नहीं करना है. And I didn't get to that. When I have to go for a smile design case, only then I pay it to the lab. Otherwise, I have trained my wingman. So in future, how I done that. These are your contraindications. Asking a little bit of deeper history of biting, nail biting, and this is surprising. Even in adults, you find it. Okay, so she might be having nice buff nails, but she's always chewing on her pen. Okay, did you observe these?
Yes.
Yeah. Which one did you like?
Third one in the previous slide.
Third one, thank you. So I also want you to imagine any one flower in your mind. Which flower did you imagine? Sunflower? Which flower? अभी तक सोच रहे हो? Okay. Rose. Which flower? Rose. Okay. Which flower? Lotus. Okay. Now aesthetic is subjective. My idea to show you all of these slides were I'm taking reference from Dr. Gallup Courier, the father of veneers, you can say. When I keep saying मैं आपको एक aesthetic smile दे रही हूँ, aesthetic smile दे रही हूँ, dentist is thinking 80-20 ratio, good nicely shaped center incisors. Lab is thinking Dr. Tasneem का case. And what is the patient thinking? She's having some figure in her head, some Aishwarya Rai fit into her face, and she's thinking about beauty in that sense. So when you say aesthetic, there are three people in the whole game. All three of them need to imagine the same flower. Yellow flower with 7 petals with reddish tinge. That is why the mock-up is the heart of your. So what did Dr. Ganef Gurian say? Can you read it? Read it loudly, please. So when did I start here and what did I ask you to do? Imagine your clinic. Imagine your final restoration and only then start working on the patient. Once you do that, you have more confidence on the predictable result that you're going to give to the patient. So all those who are very much interested in aesthetic dentistry, when you go for international courses, you'll be paying to first 2 days of only drawing. They're going to give you huge white papers followed by graph papers, and they're going to ask you to draw central incisor, lateral incisor, canine. Right, left, then sit and carve them. Why so much emphasis when we are all bothered about shade selection? दो दिन हम सिर्फ draw कर रहे हैं. Try this. When you go back, draw central incisor. Draw two more central incisors which don't look like the same central incisor. That's when you learn smile designing. How to make the patient look bold and confident. How to make the patient look delicate. How to make the patient look not middle-aged. Because you don't want them to look extra young or very old. Got it? Focus on your drawing. So, out of these three parameters, if I complete a case today and you be my examiner, which is your topmost priority?
Shade.
This slide kindly disclose. What does the patient get up and say to all the practitioners here? How many patients have come back and said, Dr. Pradeep, shade saying nahi match kiya out of your thousands of cases that you have? Any patient came back and said that? Must be a dentist. No common man will come back and say that your shade selection was. And to simplify your shade selection, when the patient comes to you, what is he asking? कैसी स्माइल चाहिए? Does he say A2 shade का थोड़ा yellow creamy बना के देना? What is the word? What is the color he picks? White. Then why are we breaking our head behind shade selection? Either he will say white or he will say मेरे दांत. Yes or no? But he will make your life if the tooth is slightly smaller than the adjacent one. If the tooth is slightly rounder than the adjacent one. If the tooth is looking like this, but a बोल नहीं पाएगा. अजीब दिख रहा है. That is why 2 days of drawing to focus on the shape of the shape of the. Okay, and when you have a restoration, a class 4 restoration, the final result is right in front of you. Yes or no? All you have to do is mimic it. Yes? Why texture is second? Sorry? To feel good. Okay, so the patient would not be feeling good. What would he be telling you? I don't feel the roughness. Patient will want a smooth restoration. But these secondary and tertiary anatomy are undulations on the teeth which give the tooth a lifelike appearance. So if you make a nice full shade match perfect shape tooth, but you've given it a glass finish, smooth like an airport runway, patient will say, well, sometimes patient doesn't say, you keep feeling dissatisfied. So texture comes your second point and third comes your shade. And shade has so much corridor of mistake. We are just hammering ourselves with shade. So the first point in shade selection is not to prejudge. So looking at my teeth or the patient, when I'm talking to the patient, इसका दांत A1, A1, A1. सोच लिया आपने, तो आप A1 पे ही अटके रह जाओगे. Now you wore first spectacles. मेरी मम्मी कहती थी घोड़े के चश्मा पहन के चलेगी तो गिरेगी. Okay? Can you pick out the best, brightest shade for me? Count from left to right. Which is the brightest shade? How many of you are looking at the syringes? Look at the syringes or purchase a composite shade by looking, opening the cap and taking it. For a composite to reflect its true shade, it has to be in a particular thickness, cured at a particular time, given by the manufacturer. So I have done that for the above discs, not for the syringes. You can see this one looks the brightest, but look at the color. And surprisingly, this is A3 of various companies. किसके A3 को trust करें? That is why you purchase an A2, you put it as A2, but you are dissatisfied. So you go to another A2. Remember, A 1, A2, A3 are nomenclature given by Vita. It was not a composite nomenclature. So if you now go and purchase a style Italian composite tape, they will have E1, white O, the nomenclature for their own shade that they have made. All the composite companies are trying to match to Vita because they taught shade guide. When an A2 is fully cured and the same A2 is cured with a poor intensity. जब झगड़ा जाके करे तो किससे? Yes or no? Yeah, I'm very proud to talk about Dr. Sumitra Mitra. She is the person who really helped dentists. We are always taking another material from another industry and adapting it to ourselves. She is the first person to invent nanotechnology for dentists. And can you guess the year when she did this? She did this in 1998. She joined 3M in 1978 and she has 178 patents to herself purely in nanotechnology. 1998 की nanotechnology मतलब she was able to split one particle to one single nanometer. If I take one hair of yours, which is 4 micron, I have to split it into the thousandth part, and that is your 4 nanometer. That is nanotechnology. She was able to discover that in 98. Until next 2002, she was struggling. वही कहानी हो गई, पार्टिकल छोटा है, स्ट्रेंथ नहीं मिल रही, एस्थेटिक्स मिल रही है. You know that composite story, right? Yes or no? She took inspiration from Greeks. She said that if each particle is 1 nanometer, let me cluster it and make it like a bunch, which will give the strength. And throughout also, I can keep single nanometers across. And with this, that is how it looks under the microscope. Where do you see true transparency? So जैसे एक्वागार्ड का फिल्टर है as compared to other, ये पानी साफ दिख रहा है, लेकिन कितना साफ दिख रहा है? Once we got this, our first attempt was, can you see the comparison? When you have two different types of filler particles, it will reflect with dispersion. But here there is going to be a true reflection. So when I think A2, I am going to get A2. Okay? When they did this, there was one more drawback. ये बना के तो दे दिए, but when they went to the natural teeth, वही A2 लगा रहे, तो still doctors are not satisfied. They came to know that where is the color actually coming from in a tooth? Is it coming from enamel? What color is enamel?
White.
It's translucent. And dentine is yellowish. Dentine is yellowish because of the organic content, the protein in it, and enamel modifies it. Whenever we are doing shade selection, we are going to do the shade selection of dentine. But where are we doing? Sitting on enamel, guessing dentine. Am I wrong? What are we doing? Sitting on enamel and guessing dentine. And when I see an anterior tooth, where is the maximum dentine? In the cervical part. Middle part is where you have enamel and dentine somewhere equal. And the incisal part is where you have true enamel. So they did the same thing. They took one A2 and they divided it into 3 more opacities. So one shade, but 3 opacities. Does it give you a better artistic look? That's what they did. That's your clear translucent. You can read the numbers behind. Then there's A2 enamel, A2 body, A2 dentine. Tell me which is the one which is completely opaque among the three opacities? Louder? It's dentine, which is completely transparent in the three opacities of enamel, body, and dentine. Enamel, which is semi-translucent, body, which is semi-opaque, again it's body. Understood? So as per the part of the tooth which is missing, you use that particular A2. Tension salt. Okay? Now let's look at this. For shade selection, first thing you need to do is complete oral profile axis. So how many of you treat your aesthetic restoration as aesthetic restoration or composite restoration? So if I start taking my aesthetic restoration as a composite restoration, I'll be charging the same thing which I charge for my other restorations. The kind of efforts that I told you in my first slide, with pre-op to post-op, do you think that is? Then I will come to a complete oral profile. ऐसा नहीं चलेगा. It's an aesthetic restoration. Treat it that way. Okay? After doing a complete oral profile axis, you should always do the shade selection in hydrated tooth. Cheek retractor लगा के phone आ गया बाहर चले गए. Your tooth becomes dry. What does a dry tooth do? It makes the tooth look brighter. Now I wanted you to say that word. How many of you think it makes the tooth look lighter? Understand the terminology of relating color. When you say bright and dark, it relates to the color of the dentine. When you say light, it relates to
Enamel.
enamel. Okay, so you see that this is the same blue which is there, but it is allowing light to pass through. Therefore, it is lighter. Whenever now you are doing a shade selection, stop judging the tooth as A1, A2, A3. What you are going to judge the tooth as? Bright or dark. Okay. Now what you are going to do now is, this is how your shade guide is, correct? Pick up the brightest. Which tab do you feel? Count from the left. Which tab do you feel is the most gora? How many believe the first is the most gora? 6. Okay. After that, do you feel this one? This one? Somewhere this one? Here is your fight. That is why when you're putting A1 and you're still not satisfied. That is why when you're putting A2, you're still not satisfied. Because bright to kitna bright. Are you getting my point? If I ask you the darkest one, which one is it? Fourth last or as per our whole arrangement, ये सबसे dark होना चाहिए ना. ये देखो ये dark. Then this comes. Then this comes. Then this comes. You have to fight amongst this darkness. So you must have seen a lot of reels and everything about this. When you do a value arrangement of your beta classical. But how do you go and do it in your clinic? Because the same blue shirt which I'm wearing now, if I go outside, might look black to you. So what you're supposed to do is take out all the tabs from your beta shade guide. The place where you do shade selection. Take out the brightest tab. Just look at the tab, not the number. Take out the darkest one. You'll get a line of arrangement. Bright to dark. इस arrangement को क्या बोलते हैं? Fair and lovely arrangement. Yes? 4 हफ्ते पहले मैं ऐसी थी. फिर ऐसी हो गई. That. Take a picture on the first day. Repeat on the second day. Repeat on the third day. You will find certain similarities and you will find certain dissimilarities. The third day picture, you compare it with this standard arrangement. How close you are. Provided you are using the same beta classical. If you are using Walnut, the shades are brighter. Okay. Now next time when you look at the tooth, you are only deciding two things. ये bright है ये dark. Now how do you do the shade selection in 5 seconds? How many seconds? Do you agree 5 seconds में हो जाएगा? Because आपको सिर्फ एक ही conclusion निकालना है कि जो टैप मैंने लगाया है दांत पे, is it bright or is it dark? If it's bright, you'll go to a darker one. If it's dark, you'll go to a brighter one. You just have to match the brightness and the darkness in 5 seconds because that is what human eye is allowing you to do. And human eye captures value first than the color. Okay, so if I have an arrangement like this and I look at a patient who's having bright teeth, I'm either going to take out B1, A1 and match, or I'm either going to take out A2, A1 and B2 and match. And previously, what did my patient say? I want white teeth. Should I be thinking कि A1 डालना है या B1 डालना? He wants white teeth. Just pick up B1 and put it up. आपको लगा मेरी लाज रची जो लगा लाइट से तो पीछे से लोग निकल जाएंगे. Thank you very much. If the system is restarting, can you just shoot 2 or 3 takeaways that you have in your mind? Or should I ask questions that you which is the most interesting part of until now? Sorry. सबका शेयर सुनाई दे उसके आगे किसी से नहीं बोलते. Sharing anything else? Sure. Anything else? You did you ever imagine that young can affect your shape? That was the most surprising part for me when I got trained. If I don't cure A2 properly, and if I'm not reading how much protein is telling me to cure for, or how much PM is telling me, I don't know my exact color. In aesthetics, that's what you're struggling for, right? And I did not understand the concept of having opaque or translucent and all those layers unless I got to understand that this is just histology, which is simplified. So one A2 can have how many opacities? Can you name the 3 opacities? And how are we able to achieve that? आप एक ही शेड को 3 opacity कैसे दे पाए? Because you had a transparent disc that you were able to achieve by true nanotechnology, which could give you an equal reflection. That is why my choice of composite is also equally important. Just the way my decision for purchasing a light is there, my decision for using a composite comes in there. Which composite is actually and which part of the tooth I can use the same. Has shade selection become easier? Let me skip all of this. Krishna. In this particular case, I and the patient both were not happy. After the case was completed, the patient was also saying, I'm difference like that. So what do you tell the patient? You start redoing it then and there. ढाई घंटे के काम के बाद ऑफिस से निकाल. What do you do? What do you tell the patient? Come after 24 hours. Anything else? 24 hours बोलेंगे, 2-3 दिन बोलेंगे, कितने दिन बोलेंगे? So when you're doing the case in isolation, your tooth becomes dehydrated and it starts looking brighter than your normal tooth. And whenever composite gets cured, it will look darker. Sometimes what doctors do is in between the layering, they feel, oh my god, this is getting darker, and they change the shade. Blunder. You should never change your shade once the shade selection is done in a prophylactic oral prophylaxis and hydrated tooth. That is the shade. Okay, and the recipe that you use after that, it's fixed. Now, when this happens, what you're supposed to say, come after 2 weeks. In those 2 weeks, after that, 2 दिन में rehydrate हो जाता है. There is organic component in your composite too. That needs to rehydrate, which will take 2 weeks. After 2 weeks, you can see even under saturation, you're not able to make out the composite. Okay? I'll skip all of this and we'll go directly to cases. Now this is interesting. Another one reason how to choose a composite. Beautiful, you cannot make out where the composite restoration is done in this case. Yes? There is transparency, there is opalescence, and then there is fluorescence. What is fluorescence? That when the patient walks into the daylight, that particular tooth will not reflect light if it's a non-fluorescent composite. So it is looking perfect shape, everything perfect. But when he walks into the daylight, you can make out कि यहाँ पर कुछ काम हुआ है. That is not giving the perfect natural fluorescence like the natural tooth. Because of nanotechnology, these composites are able to do that. So in which all aesthetic materials would you be needing fluorescence? This composite because you are using it actively. Anything else? Any other material? You have temporization. For smile designing, temporary preservation for a week or 2 weeks. If it's not fluorescent, they will not be able to appreciate your work. So Protem 4 from 3M has fluorescence. Now if you are using the perfect veneer, which is Emax, okay, which is giving you complete translucency. But if it is not fluorescent, what will happen? Again, your veneer smile design will start looking fake. Therefore, zirconia has translucency, but it looks fake. It's not able to give that fluorescence back. Your cementation that you use for those veneers need to be equally fluorescent. So all these three materials, that is composite, your temporization, and your cement for veneers, needs to be having fluorescence. Okay. So we are going to now run through cases. Okay. Imagine a diastema. First we've done the shade selection as A2. And now you have a diastema of 2M. How are you going to treat it? Since you have A2 flow, you have A2 body, A2 dentin, A2 enamel. You have 4 A2s. Which A2 to use in a diastema which is just 2M? Are you able to imagine the cases? Okay, just let me go back to this. After that, we'll go through cases. So, This is a non-fluorescent composite, and this is a fluorescent composite. Can you see some companies have tried to match it, but they have to match to the natural tea. So this looks fluorescent, but it is still lesser than the natural enamel. Okay, how would you treat this case? It's just an incisal tube. You make space for packaging. You give a nice figure. और कुछ मन किया तो बस वाले So these are tedious cases wherein you are in a dilemma. कौन सा use करें, कौन सा shade use करें. Now, this is a pure enamel space. Correct? This case is just done by A2 flow. With flow, we had a previous drawback that it used to flow a lot. We used to love it, but it flowed more on the table rather on the patient's mouth. So they changed the filler content and they gave more strength to it. It got more viscous also. Additionally, it is made with true nanotechnology. So what happens? Nice shade selection you get through reflection. With these minor particles, your attrition rate of the composite is reduced. So imagine that there are two jars. One jar is having sand and pebbles, another jar is having only sand. And you put a gel into it. Then you start rubbing those two jars. There will be a point where this pebble will pop out. It will leave a bigger crater for plaque for more stress concentration. Life of this composite restoration would be less as compared to this. Because here it's always a sand which is getting agglutinated. Additionally, because of this property, there is more polish retention. Does it affect our practice if I have more polished composite? There will be less plaque retention. My failures will be later. Okay? So three basic advantages. Now look at this. Again, this is a shade match between the competitors of flow. So when we are saying A3, we are able to deliver you that A3. Okay? Can you appreciate the pixel propensity? Can you appreciate this part wherein you can bend the cannula? Imagine your 2-7 distal cavity or a 1-1 palatal cavity where you have to struggle with the mouth mirror and you're not able to dispense your food. You can bend the cannula. Okay? This is just minimal class 3. Can you see here? Please observe. Observe this. This is the key for having longer restorations because if I ask you what is the principles of cavity preparation for a composite, what comes to your mind? Does flat pulpal flow come to your mind? Dovetail, convergence profile, those are all amalgams. And by default, we are using the same words to do the same work for composite. And then cribbing. In all your classrooms, you are using Toffel-Myers too. So Toffel-Meyer will create a box like this, and so your composite will shrink inside. Therefore, you need sectional matrices which allow the composite to flow on the buccal and the lingual side, so that your composite hugs them. Only one principle you need to remember in your composite preparation is make saucers. What are we supposed to make? Saucers, and allow the composite to hug the tooth. When it hugs the enamel, it is not able to shrink. It has a higher bond strength in. Where does it have higher bond strength? Come on. In enamel. So when it is on enamel, then it will not shrink. So if I make C, imagine this to be a class 2. So if I make a C, my composite will shrink inside. If I make an S, my composite will spread. Okay? The only advantage bioclear system of matrices has on other is it allows the composite to flow in between the matrix span and the tooth. It spills composite. Okay? Additionally, what I did is I don't have the sorry, I'm a very dentist. I don't have 36,000 to spend on a matrix system. I used a little bit of grease. For all my packable cases, I start with flow as the base, but I do not cure it. And then I pack my flow on top. So what is going to happen? My flow is going to get displaced. and then I cure them as one. That is called as snow floating. Okay. Look at the other case. This is shallow class 5. Again with just flow. No packable required. I showed you this case previously. Just flow. Does that mean I tell my patient to go back and eat everything? He broke the natural enamel. What do you expect? As simple as that. So the commitment is never at my end. It's always at the patient's end. Correct? Small bits. These are beautiful cases where you make nice time and make your occlusal anatomy. And by the time you remove all the high points, your composite is all covered. Again, you're not sure whether the pit is being covered completely or not. Again, just high strength flow here. Okay. Look at this class 2. Can you see? As I was saying, I'm making an S. This is just done with flow. Can I do the same thing on a first molar? So courageously, I did the same thing in my father's mouth when he had a little bit, but it got dislodged within 4 days. Yes, I am using nanotechnology, I am using biomimetic materials, but I cannot be that sure. The occlusion load on a first molar is more as compared to a premolar. So here it survived. This is what is the snow flow technique. Suppose you are done with your obturation. Go and take out 1 mm of more GP from your obturated canal. Then the day your obturation is done. The more you delay your obturation, the more the life of the RC is reduced. It's not that tomorrow you'll get a failure of your RC. Okay? So doing the coronal seal on the day of obturation is your 110% priority. Okay? Take out GP, bond the whole pulpal floor nicely, cure it nicely, and then you put flow. After putting flow, I have used these compules. And you pack 5 mm of composite at one go. What will happen? All the flow is going to get displaced. Okay? And then when I finish polish, can you see my flow here? That's the coronal seal. So if you remember, there was one study in which bad RCs but good crowns, and good RCs but bad crowns. Which one was having a higher survival rate? The ones with good crowns. You are seeing patients whether the PFM is nicely stuck and there is no GP inside the canal. There is a broken file in the canal. But crown is perfectly, coronal seal is your aim. Okay? When I'm using this restoration and it's a tooth number 7, my patient doesn't want to go for a crown. आजकल आरसी भारी पड़ जाती है. So they will be like, मैं 2 महीने बाद आऊंगा. Next month आऊंगा. So my whole probability of a good RC is again referring to the patient's pocket. I cannot afford that. For that, when I do my RCs, it is inclusive of the pre-endo build-up because I want my RC to be done complete sterilization. I'm not sure of the isolation. Second, it is inclusive of the either the temporary that I'm going to do or the core build-up that I'm going to do. So my RC includes these charges so that I'm assured that my RC is safe. When I'm using bulk fill composites, my expense go a little higher. And the kind of light that I'm using to cure that bulk fill is again going higher. But I'm getting assured results. Yes? Where do the RC crowns mostly fracture? When the patient gives you a one fine day, patient gives you a call and says, crown, nickel here. Where do you see the core buildup? The patient's crown most of the time. All the RCs fracture here. We have done the grade over there. When the natural tooth was there, there was roof of the pulp chamber. So whenever the patient is eating, biting, the forces are reflected. Once the roof of the pulp chamber is broken, now the forces are directed at the cervical part of the tooth. So when the crown was too sturdy, the zirconia is 3000 megapascal and it gives a lot of pressure to your underlying tooth and it breaks. Because this is the place your primary core buildup was filled with GLC, temporary, cotton, GP, ZOE, weakest of materials is dental materials. The place where you need to have most biomimetic material, you are filling it up with weak materials. You are not building up your primary core with a biomimetic material. So if I want to be a conjuice dentist, I will put 3 to 4 mm of good biomimetic material, and on the top I am going to put GLC or any root strength. But I will make sure that my coronal seal is achieved and my primary core is biomimetic. Am I making sense? So we've deviated from aesthetic dentistry. Total lectures. So like I told you how you need to purchase a bonding agent. Like a curing light. There are 2 or 3 checklist things that you need to have from your curing light. Revision. Medium intensity, thank you. Mono narrow spectrum. Diameter कितना? 10 mm. Kinetic calcium के नीचे transparent या black. Angulated या straight. Detachable या attached. Thank you very much. Now tell me how we purchase the bonding agent. High school. Which generation bonding agent would you like to purchase? 5, 6, 7, 8, 9, 10. 7. Anything else? So representatives want to give you bigger bills. 1 month he comes and says, another color bottle will come and say 8. Please understand. Textbooks have closed generations on 7th bonding agent. Are we clear with that? After that, there are only universal bonding systems which are coming with various variations. Ask them what is that variation. So my first choice for purchasing a bonding agent is universal bond. Which bond? I want to be sure whether my tooth surface is etched or unetched, my bonding agent should work. Next, I want to buy a hydrophobic or a hydrophilic bond. How many go for hydrophobic? If you raise your hand, I'll chop it off. You should ask them, is your bond hydrophilic? How will you come to know? It should have HEMA as its resin. HEMA is a hydrophilic resin. Cements which are having or resin modified GICs or resin cements which are having HEMA are hydrophilic cements. Okay? Would you want to pay full 5 ml का amount? या 5 ml पे किया है but 2 महीने में वो 2 ml उड़ गया है. Only if you find that your bonding agent caps don't fit in. There's all resin pulled up. Yes or no? So you paid for 2.5 ml, but most of it is evaporated as acetone. So I want to pay for each drop and I want to utilize it. So first is a bonding agent which is universal, hydrophilic, a bonding agent which is ethanol based. Okay? I want a bonding agent which is definitely giving me high strength. How much strength? वो ग्राफ्स दिखाते हैं आपको ब्रोशर पे. What is the number that is there in your mind to look for? आप किससे चेक करोगे? So if I take natural dentine and enamel and at the TEJ, if I'm peeling off the enamel from dentine, I need 48 megapascal strength. How much? So my base is what? 48 megapascal. How much is your bond giving me? You will find cements and bonding agents giving you a strength of 60 megapascal. Is that good or bad? Go for it. But don't go for a bonding agent which is giving you less than 30. They are doing in vitro studies, they are doing internal data analysis, and if they're showing you 60, okay, fine, let me see what it delivers in the mouth. Yes? Are we clear? So, what is your golden number to look for bonding agent strength? 48 megapascal strength. Okay? Which solvent would you like to have? Which resin would you like to have? Amount. Now to be extra sure, most of the composite resins, I'm sorry, most of the bonding agents, you'll find them more yellow in color. Have you seen that? And then you start not using it because you feel कि इसका yellow color दिखता है. अब आप मुझे बताइए कि उसका yellow color क्यों दिखता है? Curing होने के बाद भी. What was missing? Intensity was weak, so your capital could not get initiated. What was that? Secondly, each bonding agent has its own set of instructions. If you are using this bonding agent, they will definitely tell you to scrub the tooth for 20 seconds. 20 seconds? We did on this. When you open a child's mouth and scrub for 20 seconds, that 20 seconds is the time where your brain is getting etched. Because if you're using selective etch or self etch, you need the monomers inside the bond to go and etch the dentin. You need 20 seconds for the resin to be carried in the dentinal tubules. तभी तक attachment आएगा. So if we are not giving that 20 seconds, we are in the habit of scrub and cure, we will get debondings. We will get post-operative sensitivity, micro leakages and secondary leakages. Therefore, bonding is the most important part of your restoration. But getting the bond completely cured is also a part. Okay? So, I need a bonding agent which can be hydrophilic more than just the hemat. This is where they had a team of researchers to work and give us this efficacy. Can you see saliva contaminated enamel and dentin, and the constant in dentin is 30 megapascal. How did we achieve that? They invented a molecule called BCP, vitrimer copolymer. And using this in the bonding agent, they put it in their cements also. So one thing I learned in 3M is if you give them namak, they will make raita to 3M. It's an adhesive company. Their adhesive are using butterflies and their adhesives are using airplanes. Okay? This is the constant at various moisture levels at with various prototypes or self-etch techniques. Can you see the hydrophilicity now? There is a layer of bonding agent which is not cured and a drop of water. It spills, it spreads. Then there is a layer of bonding agent which is cured and then a drop of water. Okay? My major criteria for choosing any bond is one more molecule. 10 MDT. What is it? Come on. Louder please. What is 10 MDT going to do? 10 MDT empowers your bond to go and bind with the calcium of your tooth. And 10 MDT gives you additional 2 uses of the same bonding agent. Now you can use it as a zirconia primer. Now you can use it as a metal primer. So I don't purchase another 2 bottles. So when I understand my material, I start using it for multi-purpose and save. What do I save? Money. Don't you want to save money? You should not save money by going to cheaper materials. You should save money by finding out multiple uses, efficient uses. Okay. So now I can use this bond in any etching technique. Since it has VCP, I can use it in dry, wet, and moist. It is a zirconia primer. It is a metal primer. It also has activated silane in it. So another one bottle I don't purchase. I am using silane for this. Since it is completely hydrophobic once it gets cured. So how many of you are guilty applying Vaseline after GIC? क्यों लगा रहे हैं हम Vaseline? We are supposed to give a hydrophobic layer to the GIC for the next 24 hours for its maturation. Vaseline ठंडी के दिनों में आपके होठों पे कितनी देर जो गीले मुंह में 24 घंटे रहे. So you apply this and cure it. It becomes a GIC varnish. Now my GICs are more effective. Okay? I don't buy a desensitizer. I use this, scrub it for 20 seconds, cure it, and I get desensitization. Can I not prescribe Sensodyne to that patient? I can do that, right? It will take 3 months. Instant desensitization. Another one bottle that I can purchase. I can use it for composite repair. I can use it for ceramic repairs. Okay? If I tell you a story of chemical bonded composite restoration, would you believe? I'm using a bond which is having 10 MPP, that means it's going and bonding to the calcium of the food. It's the same zirconia primer. If I use it with Z350XT or a Z250XT composite that is having Z, zirconia as its filler particle, this is the bond. This is how you need to choose materials. तो हम क्या करते हैं? हम मैगी नूडल उठाते हैं और रैमेन मसाला यूज करते हैं. What are we doing? That is why we are not finding the taste. Mismatching doesn't work unless you don't understand the chemistry. This is your mantra for using this bond. If you're using another bond, ask that person, इसकी denting etching के लिए मुझे क्या करना है? Should I paint it and leave it? If I have to leave it for how many seconds? So there was a comparative study done by Dr. Arvind Shenoy, the editor of Philips Savai's Southeast edition. And he said that this is the fastest self-etching bond. Other bonds, universal bonds are good, but they have 35, 45, that much time of application. You're getting it? This is how your tooth should look like. So once you're done with etching, please rinse for 1 whole minute. You don't want any remnants of the etching to be left behind. Do not go for the frosty white appearance. You will collapse the collagen. That means you will just do the suction, take tissue and go tap tap on your tooth. You will see a moistening surface. You need a moistening surface because your bond is hydrophilic. Then you scrub it for 20 seconds. You will find your applicator tip milky. That gives you the assurity, yes, my dentine is now getting etched. Then you air dry for 5 seconds and then you cure it for 10 seconds with a 1000 intensity light. How do you go about if it was a class 2? If you put your band and then you try to scrub your bonding agent. Band is metal, bonding agent is metal primer. When you take out the band, there is one. So no banding when bonding. And when what do you do when just blood seeps in during your bonding process? You can find moisture tolerance from this bond, but no bond in the industry is giving you blood tolerance. In fact, you are trapping infection under the bonding agent. There is no complete bonding done, and you will find faster secondary various post-operative sensitivity and failures of your class 2s. Am I clear? This is what you should remember in case of layering. Okay? So, as we worked about this, now, if I were to tell you that there are so many enamels, so many dentines, that means I should purchase all syringes. A2 enamel, A2 dentine, A3 dentine, etc. What did we start playing with the value of the enamel scale? Imagine this, that I'm having a jar of glycerin and I'm putting a glass rod in. At one particular angle, you'll see that the glass disappears. What is happening? This is called as refractive index, which is giving you that illusion that it's the same thing. Okay? That illusion comes at this point, which means that an enamel should always be 0.5 mm in thickness. Can you repeat? 0.5. Okay? How do we measure that? So can you see here the recipe here? It is A1 tooth. You are going to take A1 technique, A3 enamel. In fact, you can take A2 enamel also. It doesn't make a difference. Provided you are able to maintain this 0.5 mm thickness. So this is all the shade giving sometimes I do with my patient. guilty of that because I know what shade I'm going to use. But D should feel that shade trial lupa. Yes? So you cure these buttons and then you desaturate your picture. At times if you are having confusion, कि B2 और A2 में से कौन सा better है? या A1 या B1 में से कौन सा better है? That's when you take a picture and then you desaturate. Please do not go on monochrome, vintage filters, grayscales. They will not give you the accurate result. You have to go saturation 100 minus. Okay? So after doing the oral prophylaxis, I take a impression of just the 16 and I give it to my assistant. उसको दो इंस्ट्रक्शन दिए सेम हाइट का बनाना और आगे पीछे से स्मूथ रखना. शी इज मच बेटर आर्टिस्ट देन मी. आई डोंट टीच हर सिंगल. And then she makes a putty index also for me. So by the time I'm doing oral profile axis, all of this is ready. Which enamel layering is better? Left or right? When you will see 0.5 mm thickness when your putty color reflects from below. Okay, and smoothen it. So you take this putty index to the fracture to score the putty. कितना fracture है. Then beyond that fracture you're going to layer this. Okay. You put a drop of flow over here. Any guesses? सूखा सूखा नहीं चिपकेगा. Okay, so don't go incidental. You place it over there, cure it nicely, and this is how. Can you appreciate the palatal enamel and the proximal enamel? How did I decide the proximal enamel 0.5 mm नहीं रखना है? By looking at my adjacent tooth, if that enamel is thick, I'm going to make my proximal thick. वरना अगर इसको मैं 0.5 mm बनाऊंगी, my dentine will spread and my tooth will start looking broad. Okay? So you put a section matrix vertically and then you make your proximal in enamel. So same A2 enamel palatal, A2 enamel proximal. Then you put A2 dentine, make your internal anatomy. Now to reduce from the top. Why? Why? You will reduce 0.5 mm of dentine from the top to put the final layer of enamel. So there are two syringes, but how many layers? Two syringes, but how many layers? We took A2 enamel, A2 dentine, palatal, proximal, A2 enamel, A2 enamel, A2 dentine, and one A2 enamel on top again. So how many layers? Three layers, but two syringes. Got it? If there is a case where you're seeing very much transparency between the mamelons, that means when the patient opens the mouth, there is complete light passing through. You need to create the same thing by when you make those mamelons, you have that triangular space in between, just clear translucent. If you don't put clear translucent, you are dabbing it up with enamel, it will look grey. If you put clear translucent and when the patient opens it now, light will pass. You're getting my point? So, this is the, can you see the palatal shell? Okay? Your dentine, reducing dentine, internal anatomy, final layer of enamel, final result. Make sense? Which two shades did I use? A2 enamel, A2 dentine. If the case was A3, what would I do? A2 enamel, A3 dentine. If the case was A1, what would I do? A2 enamel, A1 dentine. Are you understanding what is changing every time? Dentine, but enamel is the same. On what basis? That I'm going to keep enamel as 0.5 mm thickness only. Okay? Let's look at this case. Old composite gap. Look at the amount of removal over here. The older me would have told this patient to go for crowns. It would have been the death of it. Because वो सबसे पहले यहीं से fracture होता है. And I would, thinking of strength, would go for zirconia crowns. So after learning from these blunders, I feel there is a mismatch between longevity and survivability. Will the zirconia crown ever break? No. The tooth will always break. I am always looking for survivability, not longevity. So patient comes and says with only one thing, permanent white film. What do you want? Permanent white film. You need to set your expectations. आपका natural लगाएंगे आप permanent नहीं लग पाएगा. Whatever I am going to do is going to be equivalent to your natural teeth. And people with good teeth also in their old age have attrition. They get used up. Okay? Here I have used A1 Denti as my opaque for those dark shades. And then I'm putting A3 body. Okay, so the first use of dentine was replacing dentine histologically. Next use of dentine is using it as an opaque. Why didn't I use A3 dentine? If A3 dentine with A3 body would look too much A3. Okay? And they don't need any, this is an aged patient, does not need any translucency. Can you see? So whenever you're doing BDS, your best go-to opacity is body. Okay? Whenever dentine is missing, whenever there's a fracture, you go with enamel and dentine. Okay? This is just a class 3 case which is done with A2 body. Can you see the final result? Monochrome teeth. You don't have to think so much. Look at this teeth. It's a direct linear case and the patient wants to have white. I did a full mock-up with A1 body and B1 body. And when I do mock-up without bonding, I completely finish polishing. The patient wants to see the final result. Remember the 7 petals, the 7 yellow petals for that feeling. Once you're done with the mock-up, I ask the patient to drink water, at least rehydration. Patient said, I'll come back and I'll tell you which white I like. She did not like the B1 white also. That's when I ordered for an extra. So you might be thinking white, but you're only thinking till A1, B1. What is patient thinking? White. That's where the beauty of mock-up comes in. And now the patient thinks, yes, I'm white. And I still not like it. Okay? Can you see the difference in finishing and polishing? So as I asked you which curing light you will purchase, which bonding agent you will purchase, which composite you will purchase. If you purchase a micro-hybrid composite, look at the finishing and polishing. And imagine the same adhesive. And if you use a true nano composite, what is the performance? Okay, ultimately you are also looking for the life of the restoration, right? And here, can you see? Don't imagine these to be an anterior teeth. Let's take it as your posterior teeth. When you just use your yellow ball and give the patient finish and polish movement, that's your first scenario. If I put that tooth for 7 days in hot coffee, this is the amount of stains it's going to get. And when you follow a complete protocol, this is the amount of stains it's going to get. Understanding the demarcation between finishing and finishing. By the time you finish finishing, you should get the luster. And then you do the polish, which is to be retained. Okay? This is the extra view that you should keep in mind if you're doing a smile design. Please do not create Instagram reels to be Victor. सभी के ऐसे एक ही डेंटिस्ट का काम मैं पता कर सकती हूँ कि ये वही डेंटिस्ट क्योंकि इससे सारे सेंटर जैसे फिर वो आर्टिस्ट्री कहाँ से आएगी? Everything. Okay, how to make the laterals delicate, how to make the canines not pointed but still look female. Okay, these are divided into your 3 categories: primary, secondary, and tertiary. Your main focus is this. If you don't get this correct, these two will not fall. Okay, and I am getting this firstly, the length I am getting from my cutting legs. Therefore, my mock-up becomes the heart of my restoration. Okay, now my breath comes from the transitional line. Okay. They can be wide, regular, that's on the basis of the distance. And look at this, they can be triangular, squared, or rounded. This you get specifically when you're using a mylar strip or a matrix band to do the proximal. Avoid doing that because our centrals are not like this. They are always slightly tuned. Okay? question most of the practitioners ask me, this career काफी है, पर career काफी है. आपको फिनिशिंग पॉलिशिंग का प्रोटोकॉल भी उसी तरीके से समझना और इम्प्लीमेंट करना है जिस तरीके से आप एक डीएमपी करते हैं. 25 तक पहले चलेगा ना, फिर 40 तक क्यों जा रहे हैं? F1 हो गया तो F2 F3 तक क्यों जा रहे हैं? You know the protocol. This is the same protocol. So the first protocol is always to remove cross reduction. In case of your anterior and your posterior, most of the time you do a perfect layering, so you don't have so much of cross reduction. Cross reduction मतलब आपने 1 से 2 mm का composite थोक दिया, ऐसा कभी होता है. So I rarely use my courses. What instead I do is I use this courses for my medial ribs, places where my burr slips. Suppose you're doing an incisal edge reduction of your veneer, your burr will give you a right-handed people will have more flexion here. Instead, use the disc, it will give you uniform reduction. Use a disc interproximally. So as I said, buy the material, read about the material and find its four uses. Okay. I always start my finishing and polishing with the medium disc, which will give me the contour. This is where you need to mark your transitional line angles. And those pencil markings should be same or should be gone. How many go for same? How many sleeping? Then you supposed to be you're away. They have to stay. So while you finish, they go away. You have to repeat them. Most videos you will see that they were all thin. When you replace the 7 mm with a 7 mm, but it is still looking broad because your transition line angles are far away. Okay, so remake them. And when you make them, always run your pencil parallel to your tooth, not like this. Okay, once you're done with your contouring, contouring मतलब अच्छी contouring. इसके बाद shape में कोई change नहीं होगा. So you have to come and sit in front of the patient at 6 o'clock and look कैसा था. We do most of our work at this position. You have to come in front of the patient and see how is the front appearance looking. अब shape बराबर है. Now no changes in the shape will take place. Then you will apply your smoother. In दोनों की grids heavy है. So instead of learning this as coarse, medium and fine, learn them as grid wise. This is 120. Coarse is how much? Coarse is how much? 120. Medium is 300. How much? Fine is 600. Fine is 600. And super fine is 1200. How much is it? So you are seeing 120, 300, 600, 1200. Sandpaper use करते हैं आप, एक रफ और एक फाइन रहता है, तो कितने लेवल्स ऑफ फाइन तक जाना है? The moment I touch this super fine, my tooth will give me the polish, the luster that I was looking. Now the surface is finished to receive polish. Okay. There are additional one more system PM has, which is a paste-free polishing system. If I apply all the 4 discs on any tooth, that means I'm going to get glass finish. I cannot have any tertiary or secondary texture. So most of the times in my anterior restoration, I'm only using this disc, getting the contour, then taking my red burr and creating developmental grooves, peripalmata, and stopping. After that, I will, instead of these two being my pre-polisher, I'll use this, the beige spiral, which is having aluminium oxide paste inside it. Most systems will tell you to apply paste, and the moment you start the machine, what happens? Paste is everywhere in the mouth except that. All you need to do is drip water and touch the spirals on the tooth. It will give you a matte finish. You'll see a slight shine. That's when you stop with your pre-polisher. And then you use your fine polish. In case if I've used all my 4 discs also, I have to use my fine polish. You are using Shoko for since long. You're using Enlight or other systems. Did you have an understanding of which one to use after which one? What is the work of this one apart from this one? When we don't have an understanding and we are still using that textbook knowledge, we are being bad things. अगर आपको पता है कि इसका फंक्शन क्या है तभी तो आप उसका सही रिजल्ट एक्सपेक्ट कर सकते हैं ना. Okay? So memorize this, and whenever you are using this, it should always be dry. Can you see on the slide? What does it say? D for this, D for dry. Okay? And polishing has to be wet.
Bit.
What is this? Please purchase a pen pencil holding compass. I used to have a wooden pencil wala. It was too broad or dark. So pen pencil wala later. You replicate. Now you see the same size and the same shape of transition line and the being replicated. Okay? This tooth is divided into three parts. I don't do that usually. What I do is I come to the side of the patient, take the permission of my patient and make love. And I feel the convergence, emergence flow point. Where is the bulk exactly? And then I draw a line. Okay, the bulk is moving on the cervical. So I draw a line and I make sure कि मुझे याद रहे कि इसके ऊपर मुझे bulk है. And then I put my this in contouring shape accordingly. Okay? अगर आपका नेचुरल टीथ का bulk cervical है और आपने जो tooth का bulk बनाया वो central है, again this will be a mismatch. Once you've done it with the putty index, please don't touch the incisal edge with the perpendicular disc. It's always parallel. And these are safe-sided discs. So, and they can be flipped. Okay, so imagine you are doing distal cavity of a first molar. You cannot go inside the patient's mouth like this. You take out the disc, flip it, and in the same hand movement, you have the cutting edge on the other side. So I'm done with my medium. My shape is taken care. I'm now using my, this is a perioburr. You can use TR 25 EF also from honey. Please do not touch the tip of the burr, but the body of the burr. Okay. There's one more technique of developing this. When you're putting up your final layer of enamel, just exaggerate and layer it like in this shape. So you won't have to struggle with this. Sometimes they look quite artificial. Layering में you have the flexibility of smoothing. So what I did is पट्टी है ना, उसका एक ऐसे पतला सा सांप जैसे बना के रखा. And then when I'm layering it, I put it onto the final layer of enamel without curing. I get the shape. That is your tertiary anatomy, the perichimal. Okay? This is the time when the patient walks. When do you do finishing and polishing? Please don't start right away. You charge for an aesthetic restoration. Make him feel that he's coming for another sitting. That doesn't mean you call him tomorrow. Finishing polishing has to be done in the first 10 to 15 minutes. Unfinished composite will attract more space. So I make the patient sit outside, drink water. In the meantime, my assistant is cleaning all the negative stuff, which is putting for this under two spirals. I am sitting with a fresh concentration for the most crucial part of my restoration, the shape. Okay, so when the patient is drinking water outside, he is going to definitely, what he is going to do? Feel the restoration. Do the same thing for your posteriors. जल्दी से eye point reduce करने पर तक जाए. Let him feel he is very light. Now can you see? This is one step which we don't do ever. You only know IPR for ortho. This is where your plug gets stuck.
To direct.
Make sense? Is it achievable? How much time to give for finishing and polishing? If you clear perfectly, you understood finishing and polishing, it hardly takes 8 minutes. टाइम कहाँ लग जाता है पता है? आप खुद ही बस लगे रहते। जितनी बार डिस्क दांत पे लगेगी उतनी बार मटेरियल प्रोड्यूस होगा। Sit with focus. Don't sit with time pass. Okay? This is how you damage them. Putting too much of force or using at excessive speeds. So again, if I were to choose a finishing and polishing system, I want a paste-free system, hassle-free system. ठीक है? ये है, sorry to use the word, balatkar of the spines. These can be used for 3 to 5 restorations. They are autoclavable. I use them जब तक ये shine नहीं आती. आपके restorations कितने छोटे-छोटे होते हैं. इसलिए आप एकदम when you are expensive investment, use it wisely. Okay? Can you see when you use different materials for your polish without understanding, just using that green paste after staining, using that same paste for polishing restoration, this is the result. An astro brush with just for profile space. What polish are we seeing here? How can I expect my restoration to be longer life? And same thing, again choosing the composite or which are so a true nano composite. Can you see the difference between the filler particle? And we did 6,000 times brushing on different composites. Where do you see the reflection of the capsule? On which tab are you seeing it? Come from here. इस पे दिख रहा है? इस पे दिख रहा है? इस पे? So out of how many? 1, 2, 3, 4. Out of 7, only 3 are having good. So when they say nano fit, this is how you ask them. Show me something like this. Okay? You like to go for the cases or you back up? This one case I would like to discuss. Can you see here? The lower,
Cleansing करने
there is
किससे करो
inclusion of the lactose. Most of the time you go for the trimming. Instead what I did is I gave them a temporary perfumes to see it as a bulky feel look. I don't want to touch your centers and reduce. And this is available
लास्ट
by
में
the
स्केलिंग की
lactose.
बात तो सब
It is useful. So if this comes out, what is the result? अगर निकल के I can redo, but if I chop off your enamel, I can never redo. Okay? Stop here. Thank you very, very much.
Thank you, Dr. Tasneem, for an enlightening and thought-provoking lecture. So we shall now continue with the live demonstration. So everyone please be seated.
अभी पूरा सेटअप चेंज करना पड़ेगा चल तो फिर क्या क्या ये निकाल दो रुक पहले वो थंबनेल पे डाल दो ना
थंबनेल सीन टू पे स्विच चार्जर
ये पकड़ो
हाँ मैं लाठी है उसको कुछ नहीं
वो चार्जर दे आयुष।
भैया हाँ आ रहा हूँ बस। हाँ भैया अभी HDMI की लेंथ देखते हैं कितनी आ रही है उससे ज़्यादा पता है।
Glycemic, I feel. So let me finish this faster. What you see here is a fractured tooth. When the patient comes to me, my first job is to do documentation, patient counseling, and take an impression of this and give it to my assistant. What is my assistant going to do? On that impression, she is going to create a Is my voice audible? Yeah? Okay. So can you see the mock-up now? On the mock-up, I am going to make a putty index which will come right up to the incisal edge. Is this clear? This is all on the mock-up. Now when I come back to the patient is like this after oral prophylaxis. My shade selection is done. I feel the tooth is bright, so we are going to go with A1. In A1, what all opacities we are having? Can you name the 3 opacities for me? Enamel, body and dentine. Can you see A1 written? And there are 3 dark blue shades. Enamel, body and dentine. This one is a clear translucent. Okay, it will allow the light to completely pass through. So as per my enamel and dentine layering, I am going to use A1 enamel and A1 dentine. Okay, this is my putty index. I will go to the patient and I will mark my, this is called as scoring the putty index. I will mark my fracture line. Okay, I will mark this fracture line, give it to my assistant. Now fortunately she has learned how to layer enamel for me, and in the meantime I will prepare the bevel on this tooth. This tooth is completely beveled, but when you get a patient, take an end cutting burr and remove the unsupported enamel rods. Then take the same burr and create short serrations for a short length. Then you take the same burr and flatten it and flatten out all those serrations. So the first bevel that you created is called as an internal bevel or short bevel. Then the same internal bevel you extend and flatten it. That is called as an external bevel. Together these These are called as infinity bevel. We are going to do that on the buccal as well as on the palatal surface. Are you guys with me? Okay. I always use composites by dispensing them. So can you see E and D written? So that I know that where my enamel shade is and where my dentine shade is. Okay. Dispensing composites is a secret to saving material. When you use it directly from the syringe, firstly it is unsterile and secondly we waste material. Whenever whatever is dispensed, collect the whole thing and then put it here. So most of the times we are irritated that the composite keeps sticking to our instrument. Always remember, composite sticks to the old composite which is there on the instrument. So I am spreading. When we take smaller increments, whether anterior or posterior, we try to we ourselves create micro grabs. Okay. So now you see, now my composite started sticking to my instrument. What I'm going to do, I'm going to use tissue. So whether this is a silicone tip or a stainless steel instrument or a 10 rupee instrument, all you need to do is wipe it in between. And you don't need to spend too much on newer instruments. And you see how I'm spreading my composite? I want it to be more on the incisal edge, thin on my palatal surface. Okay. You also have modeling resin or wetting agent, which is a part of your 4th generation bonding agent, which is only having resin. There is no solvent or filler in it. You can use that to manipulate your composite, but please never use bonding agent. Firstly, it is a very expensive choice. Secondly, it has solvent, it has more camphoroquinone, and it has filler. We don't want all of that. The spreading of my composite is done. You can see palatally it is thin and incisally it is thick. I am taking a drop of flow at the fracture line, and can somebody help me cure? Yes. So when you press the putty index, you'll find little flow extruding. Just try and don't make a bulk out of it, spread it, but please don't go interdentally also. Okay? Press the putty index from behind and cure it. So, curing light should not have modes, ramp mode, pulse mode, turbo mode. We are not requiring of that. None of the composites tell you that please cure my composite at turbo mode or cure my composite at ramp mode. Okay? We only need one standard mode. Now I am reflecting. Can you see? That is my palatal shell. Now I am putting my sectional matrix band in between to make my proximal box. There is one rule when I do composite cases in my clinic. That is to have good music. Can anyone sing for me? Any Arijit sings in our campus? Keep the matrix band parallel to your buccal surface. And now, please don't hold the matrix band towards your fractured tooth. Hold it away from the fractured tooth, or else you will create a black triangle. So of lately, I have stopped using other instruments. These silicone tips are good for me. They help me spread and manipulate better. I need someone to just show a little bit of it. Can you zoom it? And when you do this, make sure that this is at the level. Don't increase the bulk, okay? If you find a void or anything, just put little flow, but of that flow. Now you understand that my putty index was there. Taking this off, I will again cure my palate. And I'm only curing for 10 seconds, and this is the ideal for my enamel shade. So my proximal box and my palatal shell is it visible? Now this becomes like a tray in which I'll be putting my dentine. Which shade of dentine am I choosing? Any answers? A1 dentine. Now fill up the whole space with A1 dentine. Right up to the bevel. When you do the etching in this case, please do etching 3 mm beyond the bevel. So you're almost going up to the cervical length. Now when you layer dentine, always remember your tooth, the natural tooth. So it is flat on the incisal edge and thicker on the middle 1/3. So pull your material accordingly. दिख रहा है? Okay. Now I am trying to create the mamelons. As I can see my adjacent tooth, the dentine is short of the incisal edge. So I am removing a little bit more dentine from the incisal edge as well. And this is creation of my mamelons. My bevel and my dentine is at the same level. Remember, we have to put one more layer. So now you're going to put this instrument. It is called as mesura. At times I don't like this, so I reduce the dentine by myself. One participant in one of our workshops, what he did is, after curing the dentine, he took a burr and then he reduced 0.5 mm. Please don't do that. So when you bevel the surface, you don't know the reduction is proper or not. You have to be sure that you reduce it as well as merge it with the bevel, or else the final layer of enamel will keep reflecting as a grey line. Okay, I am done with my dentine layer. Now in my adjacent tooth there is no incisal halo, but just to show it for the demo, I am doing it. I am taking clear translucent, okay, and I am entering it here in between these mamelons, okay, so that my light passes through. So very little clear translucent I'll be needing. Always cap your syringes immediately. There goes my clear translucent in between the mamelons. Very little quantity we need, okay. Remember, there's enamel still going to come up. So I am wearing magnifying glasses in my clinic and my hand just goes up. So my assistant knows that whenever I am raising my hand with the instrument, she has to wipe it with a tissue, okay. Spend time a little bit more on your layering. Don't leave roughened surfaces, because that will, and these are in between layers. If you leave them roughened here, it will reflect on your final layer of enamel. We don't want that. Okay. Now I am putting again enamel as my final layer. And this will go right up till my etching and bonding, which was done 3 mm beyond. Don't be conjuice. You will find this true nanofilled composite more sturdy and firm in consistency as compared to other nano hybrid or nanofilled composites, because there is no pooling of resin in this. Remember I told you, remember those 2 jars, one is filled with pebble and sand and other is having only sand. So I want to look at the tooth from the side. Now when I look at the tooth from the side, I flattened. So I'm taking a little bit of more enamel and covering it up. When you want to create a mono block of composite, what I communicate with my assistant is, if she is going to do a half round, if she is going to press half round and take it out, it's going to be around 1 mm of composite for me. If she is going to do a full round and take out dispense composite for me, she is going to take out a complete 2 mm of composite for me. Okay, so when I need complete 2 mm, I tell her full round. Oh, we forgot bonding. That is why this is a different layer coming up. Otherwise, ये दिखता नहीं ऐसे. Now I am happy with the. Can you understand this? किस तरफ दिखाऊं? Now I am happy with this. वो focus पे दबाना. This emergence. Okay, so in your layering, please keep this in mind. Most of the times we are so engrossed with this, we forget to compare ourselves with the adjacent tooth. Always touch the tooth. Now since this is a fractured tooth, the patient might say that he is having to it. Okay, so 1 or 2 seconds away, then you go close to it. Try to have minimal distance between the tooth and the light. Ask your assistant to keep pressing on cool air while you are curing. So my final layering is done. Visible? Mera square mein wo hai. Okay, now we are going to start with the finishing and polishing. So as you remember, first we will mark the transitional line angles for the adjacent tooth. Can you see my pencil lead is extended? Okay. So you come in front of the patient and on the natural teeth, first ask the patient to go outside and drink water. In the meantime, clean all of this. When the patient comes back, he'll be feeling this rough restoration in his mouth. I have the transitional line angles. Now I'm going to use better now? वो लास्ट वाले पे प्रेस करना, फोकस पे. So this is the marking for the middle third, now marking for the cervical third. Transitional line angles are the whole game changer. Okay, now I'm going to join these three. Okay, you can see that this is more straight and this is slightly rounded. So I'm going to do the same thing here. Bring it into slightly rounded variation. Okay, does it make sense, everyone? Does it make sense? Never forget your incisal abrasure. So you come here, put your mirror on and keep checking for the incisal abrasure. Okay. These are the discs that we use. Can everybody call out the grids? Course is for 120. Course is for? I can't hear you guys. 120. Medium is for 300. Fine is for 600. And super fine is for 1200. So in this layering, I will just use coarse to just shape my incisal edge and remove this interdental in between. Okay. Then I am going to contour with my medium. Then get my final shape. Okay. Now one thing I need to mark is where am I seeing the bulge of the tooth. So I will take my tooth pencil and mark it here. This is where I'm seeing the bulge. So equally I will and try to keep my bulge in this area. Okay. If the bulge was completely in the cervical, I would just draw one line. Okay. Makes life simpler and easier. Speed for this is supposed to be 15 to 20,000. So you see I am using it parallel. This is safe sided, so it can go in between the tooth also. Visible na? Dikh raha hai na? Okay. And I have to reduce the material which is, so I have to keep the line angle as the highest point, keeping that in mind. Can you just slightly slower the speed? I will not use more of coarse over here because I'm much more satisfied with my layering. I am now using my medium disc. Can you see the adaptation, the flexibility? So when you are having this, that means your speed is too high. You are supposed to slightly lower it. Best part about this is you can use an FO burr for your cingulum or you can use the same disc for your cingulum. Can you see? It goes and adapts to your cingulum. This debris when comes out, your patients start coughing. So make sure you're having high suction. Spend time with your medium disc. When sometimes you'll have to use 2 grids at times, but I prefer to go slow with my medium disc so that I have more control on my shape. I am moving my disc parallel. mineralic teeth. In hydration you get much better results. Now this is a Kanjus Jugaad. Clean this so that you get grit, okay, and you can repeat on your patient. So I specific and expensive material, but I am trying to make the most out of it. Now we can see that this tooth is looking broader, okay. It looks thin. I was using medium, now I am back to coarse because I feel that medium is going slow, okay. If I am using coarse, I cannot go directly to fine. Before that, I would like to remove the material in between. Can you see this material in between? So you can use your 12 number blade, okay, to clean this interdental space. If I would have put a wedge for making this proximal box, I would have created a black triangle, okay. Now I am observing the contour. I am कहाँ पर वो करूँ? हाँ, okay. Since I used coarse, I will go back to my medium. Please switch on. Yes. See, when I created fresh grit, again you can see the powder coming off. Don't keep running the disc, keep coming in front of the patient and observe, is it coming in shape or not. Sometimes we tend to reduce too much as is not is required. Okay, so I feel that I have reached that spot, I don't need to work anymore. If you work very nice with your medium disc, your next steps of polishing become butter. Okay, I am going with all the 4 discs now. Please switch on. दिख रहा है? Can you see the only white ring over here and then the yellow? That means you are only using that much part of the disc. You are wasting money. Make sure you use a complete. Okay? So these are quite flexible than the other discs wherein they pop out the moment you press and try to use most of it. Can you see a matte finish coming up on my composite restoration? So sometimes if your speed is too high, yellow color will come up. That is the grit of the disc will show. That time you don't have to do anything. Just lower your speed and repeat on that same spot. The grit will only go by the same disc. You cannot remove it by cotton or anything. Now you have seen that I have used the whole of the disc. Okay, I cannot do this trick with my fine disc because it is very fine. Okay, I can do that with my medium disc. I am taking another fine. Start. Slightly increase the speed as you go on the finer grits. when you see this slight polish, I don't know if you are able to see it over there. Slow करना थोड़ा सा. Can you see this slight polish, slight finish? Okay. That means the job of the fine disc is done. Okay. Start. Can you see the difference now? And mind you, this works only on composite. So the acrylic part will not shine so much as my composite will shine. I can put it in between teeth also. It's safe sided. Little. Now is it better? Can you see the shine? Are you able to see the shine, everyone? Yes? Please don't stop here. That's a finished surface which is ready to take polishing. So I'm using my final polisher. I would request doctor to help me with water. They have to drip water. Okay. Please switch on. And run the spirals like this. So some people just put water and forget it. You have to have continuous drip of water. Ye side se daliye. Put. That's it. Please don't touch the spiral like this. It will not give you shine. Only when you touch it like this, it will give you shine. Okay? You can use it very much in your cingulum also. And there my restoration is ready. Are you happy with the build up? Can you see the shine? Now even if my patient eats metal, can you see? वो नहीं दिख रहा है वहाँ पे. कहाँ दिख रहा है? The screen is frozen. Jago! Thank you very, very much for not sleeping. It's very easy to see videos, and when it goes real time, it's even more difficult. I would just like to know 1 or 2 points that you have picked up today from the live demo. Any 1 or 2 points? Come on, so that we can say thank you fast. Any takeaway from the live demo that you have? Or you've seen this on Instagram and bored today? I want you to take away one thing. Please do not take your matrix band and pull it towards your fractured tooth. You will definitely create a black triangle. The fracture that you are trying to build. People put wedges over there. I don't find a necessity most of the times. If you need a wedge, instead put flow in between the natural teeth and the matrix band. When you put wedge, you are creating a dimensional black triangle. At least when you put flow, it will stabilize it. Are you getting my point? Okay. Next, please etch 3 mm beyond your bevel. So when I finish, I am not able to see my demarcation line. In that acrylic tooth model, firstly I did not bond, and it's acrylic bonding to the composite. So my finishing polishing will be more better on the composite, and the acrylic will look dull. In case of your natural teeth, दांत और composite एक जान हो जाना चाहिए. Your aim should be like that. So So when the tooth comes like this, don't fill it like this. Spread it, spread the composite and make it hung. Are we clear? And make the patient feel your efforts of finishing and polishing. That is that 1% of your restoration which will give the life to that restoration. Only when plaque accumulation does not take place, failure cascade will not begin. For that, you need true nano composites and you need good polishing systems. Are we good to go? Thank you so much. Thank you.
Thank you, ma'am, for the demonstration. The example you shared and the practical tips you provided will undoubtedly guide us in our future activities. I would now like to call upon stage Dr. Divya Dudulwar, ma'am, to deliver the vote of thanks.
Good afternoon. On behalf of organizing committee, I would like to express my heartfelt gratitude to each one of you to make this event a grand success. First and foremost, I would like to express my thanks to our director, Dr. Rahul Hegde sir, and our dean, Dr. Anand Shigli sir, for whose support and encouragement have been instrumental in making this event possible. Now, I would like to give my sincere thanks to today's our guest, Dr. Tasneem Sheikh ma'am, for your exceptional presentation and demonstration. Your insights and expertise made a significant impact, and we are grateful for your valuable contribution. A special thanks goes to all the teaching staff of Conservative Department and Pediatric Dentistry Department and our scientific committee for your valuable contribution. I would also like to acknowledge all the PG students and interns of the Department of Conservative Dentistry and our Pediatric Dentistry Department, and all our non-teaching staff. Your collective efforts and enthusiasm have been backbone of this event. We are also deeply thankful to 3M for their generous support and collaboration. Your partnership has been crucial in bringing up this event, and we look forward for continue this fruitful relationship. Lastly, I would like to thank each and everyone present here today. Your participation and engagement have made this event truly memorable. Thank you.
Thank you, Divya, ma'am. I request is Dr. present. I request all the staff members and postgraduate students to gather in the PG library for the hands-on. But before that, we would like to click a group picture. The endo department as well as the pedo department.
बसतील का सगळं तिकडे जायचं चल मग चल मग तिकडे 3 जण उभं टाकू इकडे 2 जण असं करू बसेल का एवढं?
Yeah.